So I did go a little bit overboard with the sound effects.
That's so fun.
Thank you. I think so too. So.
Wow, that sounded like yeah.
Oh.
Kate was going hard on that.
Is this
Yeah.
your personality? Your secret personality coming out?
No. Okay. Oh, so by the way, what all that meant was left ventricular hypertrophy, benign early repolarization in WPW. Okay. So we'll get to that. Okay. So we're going to start. All of these are the last three STEMI mimics that we're going to talk about. And I think of the three, the most important one is left ventricular hypertrophy. And that's one that is a medic, at least in most areas, you're expected to be able to recognize what the importance of it is. Fortunately, it's pretty easy. You just have to, it's like yet another thing not so hard. You just have to learn it and remember it. So what this is we used to have a really great externship in a place called Wake County in North Carolina. And it was really a great place for our students to go on externship, partly because it was very progressive, partly because they really liked us. It was also a big area that incorporated both urban and extremely rural areas, so it was a nice mix. And also, they hired our students for jobs. And then the pandemic happened, and then they got a new person in charge of the ambulance service, and it just, the way it happens sometimes, it just kind of fell apart. But the reason I have this is because way back I didn't used to teach LVH because I thought, well, it doesn't really make that much difference. And I got an email from one of the students who was in Wake County and said, hey, you should start teaching LVH because we are expected to know it. And so I thought, oh, thanks for telling me. And after that, I added it in. This is their STEMI activation. I think I've cut off a portion of it. I honestly don't know if this is what they still have. This is a bit old, but it still is a good example of why we need to know LVH. So they're talking about what to do with the STEMI activation. And then they're saying the things that, if you see it in red, that means you can't do a STEMI activation until you transmit the 12th lead. You can't do it on your own. And if you see, so you can see one of them is pacemakers. The other is presence of LVH. And so what they're telling you in this protocol is the medics had the responsibility to start the STEMI activation on their own, even if they also transmitted the 12 lead, but were told if you see LVH, you cannot do a STEMI activation. Now I agree with about half of that, and when we get to it, I'll show you where I think it's very appropriate to do a STEMI activation, even if you have LVH, and when I think it's not appropriate to do so. Okay, so first of all, Brandon, what is left ventricular hypertrophy? Just what is the condition? What are we talking about here?
Large left ventricle.
Yeah, so remember, trophy means development, hyper means excessive, and left ventricular. So it's excessive development of the left ventricle. So it's an increase in the mass, the cardiac muscle of the left ventricle, okay? And it can be secondary to either an increase in wall thickness or else the cavity itself simply becomes larger, or both, okay? Usually it's an increase in the wall thickness, with or without a increase in cavity size. Here's an extreme example. I have no idea, I just pulled this off. I thought that's a good image. So LVH, so here's another one. You can see how thick, we're used to looking at pictures of the left ventricle, and you can see, oh, wait a minute, wow, this is really overdeveloped. LVH is caused by two basic mechanisms, or possibly a combination. Pressure overload when, this is one of the many, many reasons why people should not have chronic hypertension, is that forces the heart to pump against increased resistance. And that, among other things, that can lead to LVH, because you're forcing your heart to work harder than it's meant to work. And then volume overload. So if your aortic valve, something called aortic valve insufficiency, meaning what it is in the name, is your aortic valve doesn't shut properly. So what happens is that blood is always sort of going backwards. It leaks backwards, and so the heart again is forced to pump more than it normally would. Okay, so. So when confronted with the extra workload, heart muscle increases. It develops over months to years. So we're not talking about something that happens overnight. It's the continuous overwork of the heart. And aside, and probably some or all of you know this, is that there also is a form of left ventricular hypertrophy known as athlete's heart. Because if you think of it, an elite athlete frequently will, their heart has to also work harder than normal. It's not considered pathological, and that's not what we're talking about today. So why is this a bad thing? Why would you care that your heart muscle has become hypertrophied? Well, so first of all, a big one is that if the hypertrophy is too extreme, the muscle itself will become stiff. And that's a problem, because we want our heart to be able to be extensible so that it can get a proper preload. And if the muscle becomes stiff, that prevents proper filling. Another thing is the enlarged muscle. Remember, we talked about how sometimes, way back in the fall, sometimes the left ventricular muscle can compress the vessels when it's pumping. And if the muscle has become so thick, there's more of a tendency for it to compress its own blood vessels, leading to some ischemia. And then, of course, this is a pathological condition, and if it goes on for years, your heart is overworked, and it's overworked, and it's overworked, and eventually it will weaken, leading to heart failure, among other things. So the further complications of left ventricular hypertrophy are insufficient supply of blood, heart failure, arrhythmias, acute MI, and sudden arrest. So here we're going to talk about how you pick out LVH from a 12 lead in ECG, what the ECG changes are. But just to be clear, and this I think makes sense, is definitive diagnosis, it takes an echocardiogram. So you can see here's left LVH and here's normal. So why do we care about LVH? Well, the truth is we don't care all that much. Because for us, for paramedics, LVH does not have much clinical significance. If you note LVH on the 12 lead, really in terms of clinical significance, the only thing it tells you is, okay, this person has a history of some heart condition here. Okay, so it does tell you that, but past that, there's nothing that, aside from how you approach a STEMI, there's nothing that we change in our treatment of somebody with LVH and somebody without. So clinically, it really has almost, for us, for paramedics, no real clinical significance. However, LVH can mimic a STEMI, and very specifically, as you'll see, it mimics a septal anterior STEMI, and that's where it can trip us up. So that's why we're learning about it today. And it's not just that it mimics the STEMI, but it has other things that it simply becomes a difficult 12 lead by the fact that it's LVH. It is also, what you're going to find is it's pretty common amongst your patients. It's not, amongst the general population, not as much, but your patients, there'll be a lot of LVH. So of course, we're going to look at lots of examples, but we're going to start talking about some right now. Somewhat widened QRS. Now, if you go back to the fall when we were measuring the QRS, time and again we would hit these, I'm asking you, is this a wide QRS or not? And you've got your calipers and you're looking and thinking, I don't know, it's like right on the border. Good chance that was LVH. It tends to widen out the QRS, but not necessarily so much that it's actually an IVCD. So these will be the, so 3 small boxes, less than 3 small boxes is our criteria. These will be the 12 leads where it's like 2 small boxes, 2.5 small boxes, and they're widened a little bit. And it makes sense because if you think about what the QRS widening means, it simply means that it takes longer for the heart to depolarize. And if you have additionally thickened muscle, it just takes that much longer for it to depolarize, but not that much longer, because it doesn't necessarily mean there's any problem with the conduction system. Left axis deviation sometimes, but I wouldn't, that's not going to be terribly helpful for you because you'll be able to see the LVH based on other criteria, and sometimes, okay? ST segment and T wave abnormalities. This is where the money's at in this lecture, okay? ST segment and T wave abnormalities, what that means is ST elevation and ST depression. The term for that, as we will use, there's what's considered an older term, which is strain pattern, okay? Because not all LVH mimics a STEMI, but if it does, we call it strain pattern. And it's one of those things that it's like, oh, this is an old term, but everybody uses it because it's the easiest way to say it, and I'm going to continue to use it. Now, these are the generalized EC. Oh, and I've skipped the big one, is the QRS typically is taller, okay, or deeper. These are the generalized ECG changes, but there are some very specific ways that you can look at the ECG and say, yes, there is LVH, okay? In fact, there's a whole bunch of criteria systems that you can use to determine LVH. There's a bunch of them. We're going to start by talking about the most commonly used one, and then I'm going to add a couple of others that I think are useful. This is one of these things that you're going to look at and say, I thought you said this is easy. This is easy. It's like one of those things, once you know what to do, it actually is easy, okay? So I'll read it just for laughs. Add the depth of the S wave in V1 to the height of the R wave in V5 or V6, whichever is tallest. If it's greater than 35 millimeters, LVH is present. And I know that this sounds really miserable, but it's actually quite easy. It's just another one of those things, as long as you remember it, it's easy to do. Okay, do we have LVH based on this system? Well, the first part of the system was to look at V1, okay, V1, and you measure by small boxes, which are millimeters, how many small boxes, how many millimeters is the depth. Even if there was an R wave poking up above, it doesn't count. We're just looking at either the Q wave or the S wave, whichever one goes deepest, okay? And in this case, if you count up the little boxes from the isoelectric line there, 17 millimeters, okay? So then you look at V5 and V6, and you're looking at the R wave, the vertical component, And Riley, what you're going to do is you're going to pick either V5 or V6 based on whichever one is tallest. So which one does that appear to be?
V5.
Okay. And then you do the same thing there from the tip of the T wave down to the J point is how many millimeters? Okay. And we've got 22 millimeters. And Kyle, I know you're tired, but how much is 17 plus 22?
My final answer is 39.
Okay, we'll see. Yes, okay. And then Cody is 39 greater or less than 35?
39, what is bigger? Jeffrey style.
Yeah.
Bigger, 39.
Okay,
39.
okay, okay.
That was a myth.
Okay, okay. And so 35 is the cutoff. So in this case, we have LVH because you add V1 to whichever is biggest of V5 or V6. If it's over 35, bingo, it's LVH. Okay, so again, Natalie, if you want to do this one, and you can do sort of approximate. This one is actually going to be pretty easy.
It's
So,
a little bigger.
yeah.
It's like 5, 10, 15, 20, 25, 30.
Yeah, and it's
Yeah,
this.
all
So
right.
all we need is 5. And really, this is sometimes and squinting, because sometimes this is the hardest part of LVH, is to see, because the R waves and the S waves run into each other. So you can see the tip from here to here. And is this one greater than that one? Who knows? So definitely LVH. Okay. Okay. And then Grace, what about this one?
No.
Okay, but let's do it. I mean, you're. So what's that about? 8? Do you think?
Yeah.
Okay, and you're right. No, okay, no LVH. Okay, so I'm going to give you 2 other criteria you can use, but if only one of them is correct, you're fine. You don't have to. I'm going to give you a total of 3 criteria. I want you to know all 3, but you don't have to use all 3, if that makes sense. Okay, so if any one of the 3, so let's look and you'll see what I'm talking about. More criteria, and if any of the following are present, the first one, you add it together greater than 35, stop, you're done, it's LVH. Or another way you can do it is you can take the height of any QRS, any V lead, and if the entirety from the top of the R to the bottom of the S is greater than or equal to 45, then you've got LVH. Okay, so you could do that instead of the first one. If you have these great big tall ones, you might think, oh, instead of adding up all this garbage, I'm just going to look to see if we have 45. And then a kind of a handy one, this one is actually a good one, but it's just not always true. So which is the R wave in AVL is greater than or equal to 12 to 15 millimeters. 12 to 15, what does that mean? Some references say 12, some references say 15. And that's kind of a quick one. Now, if you look at a 12 lead and the R wave is, let's say it's 5 millimeters, that doesn't mean it's not LVH, you just move on to another criteria. So any single criteria of the 3 that I've given you means it's LVH. You don't have to do all 3. So I think, let's see, where am I here? Oh, okay. So this is just an example here, okay? So first of all, you can see this one, that third criteria is really handy because you can just glance at it and say, heck yeah, it's greater than 15 millimeters. I'm done. I don't have to add anything. So that's a nice handy one. And then if you look, it goes from the bottom is here and the top is here, and that's greater than 45 millimeters. And then, of course, the original one also, this was the one that I think Nicole did. Okay, so all 3 criteria, sorry, Natalie. So all 3 criteria fit this one. So what I want you to do is pick up your handout, and there's there's 8 different examples, and I want you to say, is there LVH and what criteria are you using?
Or later.
Those handouts, okay.
Which one? Hey, how many did you say to do, sorry?
Well, it's all of them really, but there's 8. You'll see it. Okay, Ann, what do you got for this one?
I said yes, and because the QRS, the entire QRS in several B leads are greater than 45.
And which one did you remember?
Oh,
You could use a bunch of them, couldn't you?
Yeah.
Yeah.
B2.
Okay. And what other criteria could you use? I understand that's what you used. What else? Or did anybody use anything different beside greater than 40?
Yeah.
Yeah, all of them. This was one where AVL is greater than 12 to 15, and obviously if you add V1 to V5 or V6, it is. So definitely LVH. Okay, so Grace, what about number 2, please?
Is it no? It was not using the V1 S wave and the V6.
Okay, so did anybody get anything different?
I said yes for ABO.
Yeah, it is. Yeah, actually, it is. Yes, but it's kind of borderline. It's about, I said 12 to 15. How many did you get for this? Let's see. It's 5, 10, 15, 20, 25. It's like 32, 33. So it's very borderline. Yeah. Let's see. Yeah. So the printout says LVH. So it's very borderline for everything. So in terms of, was this on a quiz, I wouldn't mark it wrong, but it is very borderline.
But with this one, could you call a STEMI then if it's borderline because they mimic the septal anterior, right? So if you're having
I would not call this one, and we'll get to it for a couple of reasons. One is it's really, remember the V2 and V3 have to be at least 1.5 to 2. It's right on the border of that. And the fact that it is LVH makes it pretty suspect. And I don't see anything else otherwise. That doesn't look good right there. I wouldn't call a STEMI based on this, but we'll get to the strain pattern in a bit. Good question, though. Okay, so Natalie, next one, please.
I said no for this one, and I added V1 and V6 together. It was
Yeah.
V6 and definitely not V5.
Yeah. So remember, any one will work, but in this case, all 3 don't work, so absolutely, so no here, okay? So Brandon, number 4, please.
I said yes because ABO was over 15.
Okay, and then did anybody else use any other criteria? Yeah, so the additive one clearly works, right? If you add this to this. Were there any 45s?
Yeah.
Mm-hmm.
I did
V2? Yeah, so all 3 criteria are working here. Kyle, what about this one?
I said yes, you can add V1 and V6 and get over 35.
Correct, and V6 by itself is pretty much over 35, isn't it? Yeah, okay, so this is another one. Riley, but what about number 6?
I said no.
Yeah, so nothing there. And then Cohen, number 7.
7, I added V1's S wave plus, I can't even look at V5, but even with
Right.
V6, it still adds up
Right.
to greater than 35.
Yeah, and probably this one, you can't see it, is the problem. Probably this one is 40, it's hard to, yeah, it's probably 45 too. But yeah, absolutely. And then Cody, what about our last, is this our last one? Yeah, the last one.
I said no for this
Okay.
one.
Yeah, so none. So again, it's one of those things that's pretty easy. You just have to remember it. Obviously, it's also on the printout. I think this is a good one to keep fresh, though, and being able to do it on your own. So,
Hey, Kate,
yes.
my question is, where do you measure exactly? Like, where do you start to measure? Like on the R wave?
I would do it from the J point, so I would include the ST elevation. Again, part of the problem with this is, like we saw the one that Grace did that was kind of borderline and depended on AVL, it was about 13, so it was borderline. The numbers are kind of arbitrary.
Okay.
So if you get something that is like 34, I wouldn't go, oh, I probably would say, yeah, I was probably it. So, okay. Okay, so let's go back here. So why do we care? We've already sort of said this. The reason we care is because it can mimic a STEMI. That is the main reason. Now, it doesn't always mimic a STEMI, okay? Sometimes there's no extra ST elevation because of the LVH. But if it does, the old term for it, which is what everybody uses, is strain pattern. So there's LVH, and then there's LVH with strain. And when you say with strain, that means it has some ST elevation. So the new term for it is repolarization abnormalities in LVH, which is why everybody says strain pattern. Okay, so it's just so much simpler. And then just to repeat, so we're clear, not all LVH mimic a STEMI, but when they do, we say it's LVH with strain. And to be clear, some aspects of strain mimic a STEMI, but there's some aspects that are just strain and not so much. Okay, so what am I talking about? What is strain pattern? The big one for us is ST elevation. Strain pattern associated with the LVH is ST elevation, most commonly in the early chest leads, the early V leads, specifically V1 through V3. Okay? And when we're talking about strain pattern, it includes a bunch of different stuff, but ST elevation is the one that really mimics a STEMI. So there are other parts of strain pattern, one of which is the deeper the S wave, the greater the ST elevation. So if the ST elevation is present because of LVH, you will notice that the leads that have really deep S waves will have greater ST elevation. And then also we're going back to that concave upwards pattern as opposed to convex, just like pericarditis. So let's look at some pictures. So again, this is the concave upwards that we saw with pericarditis. LVH causes ST elevation, but typically it is concave upwards. It swoops upwards. Okay? So if we look, you can see here's the ST elevation, ST elevation, ST elevation. It's these three leads, and this is very dramatic. That swoopiness. And some people say a good way to remember it is it's a smiley pattern. It's benign, and it's not necessarily benign, but it's better if it's upwardly concave, okay? And again, typically it's V1 through V3. So that means, I've already given this away, but which STEMI does LVH most commonly mimic? Yeah, septal anterior.
Hey, Kate,
Yes.
can we go back to the last slide of that 12 lead real quick? Does LVH with strain just kind of present with discordance similar to
Yes.
at the left bundle branch? 'Cause
Yes.
There's
Yes.
Inverted T waves and stuff.
Yep.
The lateral leads.
Yeah, but again, not necessarily. Well, this one actually does. Yeah, but again, it's the same thing, and that idea of the S wave, the deeper the S wave, the greater the ST elevation. You'll see that with bundle branch blocks too. Okay, so there's our little smiley. Okay. Now, other things that can happen because of LVH is ST depression with T wave inversion. So this is another thing. If you have I would say if you have LVH, be really skeptical of any septal anterior STEMI, be really skeptical of any non-ST elevation ACS, because ST depression is part of that strain pattern that frequently is associated with LVH. Okay, commonly seen with these leads, it has a down-sloping curve. We'll look at that in a minute. The T waves are not deep, usually asymmetrical. And again, the taller the R wave, the greater the ST depression. So what's all that about? This. And you know, we've seen this pattern lots and lots and lots. We just, you know, have, because we didn't talk about LVH yet, we didn't talk about it. But what you'll see is there's ST depression, but typically, remember when we talked about ST depression, we said some ST depression is worse than others, and if it's flat or it's down sloping, it typically is more associated with reciprocal changes and ischemia and so forth. And that's because of LVH. If it curves upwards like that, it's much more likely, it's definitely ST depression, but it's much more likely to be there because of LVH, okay? Yeah. And again, this idea that if you're looking at LVH, one thing you might notice, the leads that have ST elevation, which typically are V1 through V3, the deeper the S wave, the greater the ST elevation. And if they have ST depression, the taller the R wave, the greater the ST depression. So let's look and see what we can see here. So this is LVH, and it has what we think of as some strain pattern. So not so much anything in V1, V2, or V3, but what we do notice is this. This is very classic strain pattern. This one, interestingly enough, is not. So hard to say what that is exactly. Some people say that the strain pattern is like a check mark, and that's never quite resonated with me. But if it helps you to remember the pattern, by all means use it. You'll hear it a lot. And I think the check is like from here to here, sort of this, like that. It's that very specific thing. Okay. Okay, now we've got a lot of, you know, clearly it's LVH. I don't think I have to persuade anybody of that. And you can see, again, we have ST elevation in V1 through V3, tiny bit in V4. We have our ST depression with that very specific pattern in V6, tiny bit in V5, and also we have a little more ST depression here. But you can see throughout the ST elevation is associated with concave upwards. And this is like about as classic as it gets. You can see why people, if you don't know about it, why you would say it was a septal anterior STEMI. Okay, so what do we have here? This is more of that ST depression, a little bit of ST elevation, not much. Okay. And then here's a very dramatic one. So again, if you didn't know about LVH, you would say, oh, septal anterior STEMI, let's do a STEMI activation. In a minute, we're going to talk about what you do if you have LVH, okay? So you can see that. Going back to this one we had before, and this one, you can see there is some ST elevation. This is the one that had borderline, depending exactly how you counted it, just barely LVH, but it has some ST elevation there. And I think this one you'd have to be very careful about doing a STEMI activation. And finally, one more. Okay. Okay. Now, if you go back and you remember what I started off by showing you, the protocol, the Wake County protocol, and it said if you have LVH, you cannot do a STEMI activation. I agree with that as it pertains to septal anterior leads. I don't agree with that at all if it's another part, like say inferior leads, okay? So for example, this one here is, you can add this together and you'll get, and you're going to get LVH. But if you look here, this has nothing to do with strain pattern. It's not any, for one thing, it's the wrong leads, it's not concave upwards, it's got reciprocal changes. The reciprocal changes are that flat kind of ST depression. So from my point of view, if you work in an area that says don't do a STEMI activation with LVH and you get this, to me that's kind of foolishness. So what I would do if you worked in an area that says no STEMI activation with LVH is I would call them up, I would describe what I saw, I would send it off, and go from there. But so for me, if it doesn't look like strain pattern and it looks very much like a STEMI, then by all means do a STEMI activation. But just be aware, you should also say it's LVH. Now we had a student who worked, really good student actually, who worked there for a number of years, and she's, after she was there for a few years, she went to med school and is now a resident. And I remember asking her, I said, Kara, so what do you do if you have something like this in Wake County? They say you can't do a STEMI activation. And she said, well, the way it worked there was they put so much weight on the knowledge and opinion of the paramedics that you would call up in this case and you would get it activated. So it was something that was not written into the protocols, but that's how it worked. Okay. What's this?
LVH within IBCD.
Keep going.
Left bundle.
It's a left bundle branch block. Okay, if I showed you this at the beginning, everybody would have said left bundle branch block, but I've muddied the waters by talking about LVH. This is a left bundle branch block, but fits the criteria of LVH. So what do we do about this? Okay, here's the rule. Next slide. Here's the rule. You cannot identify LVH in the setting from an ECG, in the setting of left bundle branch block. Okay? Left bundle branch block masks LVH just like it masks everything else because the left bundle branch block shows left bundle branch block. Call it left bundle branch block. Don't even worry about LVH. Is it possible that that patient has hypertrophied left ventricle? Yes, of course it's possible, okay? But you can't tell it from the ECG. So you've got, that's a really important thing. If you're, it's like I'm not surprised you said LVH because we're talking about LVH and you start looking for the criteria. So keep it separate in your mind. There's left bundle branch block. Once you get left bundle branch block, you don't have to worry about looking for LVH. Because you can't, it screws it up. Okay, so here's my take-home lesson for this part of the lecture. Look for LVH, and if you describe the 12 lead as part of your HERE report, always mention you have LVH. Never leave that out. If you are, if you're describing the 12 lead and what you see, that is a critical thing. One of the reasons why they say to paramedics, you can't do a STEMI activation with LVH is that is, I believe, the largest cause of unjustified STEMI activations that come from ambulances is that people have a patient with LVH, see strain pattern, and go for STEMI activation. But if you're smart about it and really know what you're looking for, I think you can call a STEMI activation as long as it's the correct STEMI activation. Okay. Remember, LVH mimics an anterior septal. Don't ignore more obvious signs of ischemia in the inferior and lateral leads. Okay, so that's everything on LVH. Do you have any questions about it? Okay. That's not the end. Don't get excited. It's the end of this part. Okay, so benign early repolarization, that's kind of an older term these days. It's more frequently called early repolarization. I think because there's some knowledge, it might be not quite as benign as thought, but I'm still using the old term. So, this is a 12 lead with a whole bunch of ST elevation, okay? Not only that, but the monitor is declaring a STEMI alert. So you can see ST elevation, consider anterior lateral injury or acute infarct. So the monitor's ready to do a STEMI activation. Now there is something here that is very suspect. It doesn't make it impossible. Forget about the 12 lead for a minute and just do a quick read through of the printout. There's something there that's a little, not impossible, but a little odd. Really young, they're only 20 years old. Now, do 20-year-olds sometimes have STEMIs? Yes, they do, okay? So we're not, however, that being said, it's unusual, okay? So benign early repolarization, again, these days it's more frequently called early repolarization, is many healthy young people, more men than women. The common demographic for benign early repol is healthy young men. Display ST elevation, typically V1 through V4. The one before, I think, had it in the later leads as well, and sometimes in 2, 3 AVF. So pretty, kind of everywhere. So early repol findings. Again, this is a little bit like the pericarditis checklist. In fact, it has some similar things. ST elevation in 2 is greater than 3, more likely to be early repol. Upwardly concave, more likely to be early repol. Notch at the J point, we'll look at that in a minute. No, again, this is the big one, no reciprocal changes of ST depression except, in AVR V1. That reminds me, I didn't say something about the quiz, okay? This business, but it fits here too, about, let's go back, take a little break and talk for a minute about pericarditis, okay? Pericarditis should not have any ST depression except possibly in AVR and V1, okay? Does that sound familiar? No ST depression, and the same thing is true with benign early repol. Should not have any ST depression except possibly in AVR and V1. If you see ST depression in AVR V1, it does not make either pericarditis or benign early repol more likely. It's a neutral, okay? So I got people on the quiz who said, I think this is pericarditis because I see ST depression in AVR and V1. It doesn't increase the likelihood of pericarditis. It's just that if you see ST depression in any other leads, it decreases the likelihood of pericarditis. Okay, same thing here. Doesn't mean if you see, where is it? ST depression in AVR V1, it doesn't increase the likelihood of benign early repol, but it doesn't increase or decrease it. It's a neutral. Did I say that correctly? Did everybody follow that? Okay. Again, no reciprocal changes. So this is a big one with all of the mimics, with pericarditis, benign early repol, LVH, the whole thing. They don't change. Remember how dynamic we've seen STEMIs likely to be? If you have a suspected STEMI and you're doing serial ECGs, if things are changing, that's not pericarditis, that's not benign early repol, that's not LVH or any of them, okay? What's the notch about? This is a notch, like that, okay? So these are, again, I'm showing you here, these are all benign early repol QRS, well, just the whole complex. You can see how they're upwardly concave, and this is a more clear notch. This is just kind of a ding, but that's like a half-formed notch. And again, like LVH and pericarditis, we want concave upwards, smiley face. Okay, so This was the original one, so let's see why this did turn out to be an early repole, okay? So what are the ECG findings? Well, first of all, the ST elevation in 2 is greater than 3, okay? Elevated, they're all pretty upwardly concave, except V3 is flattened out a little bit. Notch at the J point. We see it there, we see it there, we see it there, we see it there. You see all the notches. And no ST depression. There's a little bit in AVR, but again, that doesn't mean anything. Okay? Okay. So so again, ST elevation in 2 greater than 3. Actually, it's about equal here, I think. Elevated ST segment tends to be concave. You can see that all over. Notch, there's a notch here, notch here. Everybody understand what I mean by notches? Okay, okay. And then big one, no reciprocal changes or ST depression. Actually here, maybe a tiny bit in AVR, but there's none anywhere. Okay, another one. Okay. Not sure I agree with that one. I think that's more, again, equal. Elevated ST segment tends to be concave, notch at the J point, and so on. Okay, here's another one. These are all benign early repole. Another one. Okay, so how do you deal with this? Well, first of all, you're not going to have to deal with it as much as you think. Because remember the demographic is young men. And that's not, while it's not unheard of for us to do 12 leads on, sort of healthy young men, it doesn't happen nearly as much as, elderly, less healthy people. I think the way that I would handle benign early repole, if you have a otherwise healthy young man who's exhibiting chest pain, you do this 12 lead and you're looking at it. I personally would say this is a case where I think you should err on caution. That you should tell them the age, you should say this might be early repole, but I do see ST elevation. The patient is 20 years old, but I'm going to come in however you want, maybe code 3 based on clinical experience, and just alert them to the, and say, I don't know if this is a STEMI, because I understand, it's hard to separate it out. So it's not like left bundle branch block, where you know that what you're seeing mimics a STEMI, yeah.
Is there a typical symptomology we can kind of link to this? If there's a
No, because it's really possible if we did a 12 lead on all of you, that some of you would be in early repole. There are no symptoms unless, the thing is where it gets confusing is, well, what do you do if somebody has symptoms of ACS? They're young and you put them on and you see these 12 leads that have ST elevation, but they have notching and they have all this stuff.
Okay.
So I think it's not straightforward. Just know that it exists, and if you bring it in as a STEMI, and it turns out to be benign early repole, personally I wouldn't feel particularly bad, because it's very hard to tease it apart. What do you do if we know that the patient should most likely have upwardly concave ST segments? Well, what do you do if there's three leads that have convex? At that point, I would be worried, but it's not cut and dried. I guess this is not a cut and dried one, but it's good to know about, because if you do bring somebody in as a STEMI alert, I don't think anybody's going to. It's not like a left bundle branch block. I can't guarantee you that nobody will get annoyed at you, because they get annoyed at you for nothing sometimes, so for doing your job. But I don't think you should feel bad. But if they turn around and say, no, this wasn't a STEMI, this was just early repolarization, you go, oh, okay, well, so does that make sense? Okay, so in terms of, this is another one. If you look at that list on the study guide, I do not have pericarditis of things you have to pick out from a 12 lead. I don't have pericarditis. I don't have benign early repole because I think these things are hard to pick out. That doesn't mean you don't have to know about them. If I show you a 12 lead bit and say this is benign early repole, tell me what the ECG findings are, just like I did with pericarditis. Okay, so WPW, what's WPW? Okay, and what causes it? Yeah, you're correct, but it's actually the accessory pathway that causes the, okay. Yeah. So we've already talked, so we're going to do WPW ECG changes. And we'll go through, I know you remember, oh, here's the circle, just like you were saying. Remember, WPW is an accessory pathway, and it can cause, among other things, SVT because of a macro re-entry circuit that is created between the AV node and the accessory pathway. Okay. That being said, if somebody has WPW, the vast majority of time, they're just in a normal sinus rhythm. Okay. There's many times, this is something people are born with, and there's many times that people don't realize they have WPW until maybe they're like 23 or something, and all of a sudden they have SVT, and they go in and it's like, oh, you have WPW, and their whole life they've had WPW and not realized it. So most of the time it's not something that people know about. There are some ECG changes that I do want you to know and be able to recognize. If you look on that list in the study guide, one of the things that you are going to be looking for in the 12 leads is WPW. That means you have to know how to pick it out. Okay. So the big thing is the delta wave, and the delta wave, because of the delta wave, which we're going to talk about in a few minutes, because of the delta wave, that means the PR interval is short, and the QRS tends to be sort of wide-ish. Okay. So what is the delta wave? Have you had this in any meta-merger? No. Okay. Okay. So usually a person with WPW is in a normal sinus rhythm and feels no ill effects at all. But again, the ECG has several distinguishing features. The delta wave is this right there. It's subtle, but if you're looking for it, you can see it. Can you see how, here's a good one to see. Can you see how it's almost like the QRS kind of kicks its leg out? The R wave kind of kicks the bottom out. And instead of coming straight down like we're used to, you can see there's a little thing here, and it sort of goes off, and it shoots out toward the PR interval. And the PR interval, because of that, is really short. And if you measure the QRS at this point, because of that delta wave, it tends to be a little bit wide, okay? So you can see this is a good one because there's a little bit of a delta wave here, hard to see here, hard to see here. Now, if it's, well, actually you can see it here, it's right there. If the QRS is inverted, it's actually downward pointing. There's the delta wave, it's just flipped over because the QRS is flipped over. Okay, there's one. Does anybody have any trouble seeing what I'm seeing? Can you see that? Okay. So if we blow that up, here is what the QRS would normally look at, like, whether there's a Q wave or not. But the delta wave starts at about the end of the P wave, or maybe a little bit further, which is why the PR interval is so short. And it slopes upward, and then the rest of the QRS is just the way it normally is. Okay, so what causes the delta wave? Let's see. What I'm going to
Can you see
do.
the delta wave if they're in SVT?
No, you can't. Yes, yes. And when you see what causes it and you think about it, you'll see why. So actually, I'm going to skip till I get to the picture. And then I'm going to come back. Okay. So what happens normally is if somebody has an accessory pathway, that doesn't affect anything in the atria. So the SA node fires off as it normally does. The impulse goes down through the conduction system to the AV node. The atria depolarize like normal. However, what is unusual is that here's our accessory pathway here, okay? When the atria depolarize, they hit the accessory pathway. So now we have a situation where impulses have hit both the AV node and the accessory pathway, okay? So instead of having impulses travel down to the ventricles through one area, just the AV node, which is normal, we now have also electricity traveling down from the atria to the ventricles through the accessory pathway. Okay? What can you tell me about what happens to the speed of conduction in the AV node? It pauses, it slows down, okay? So it takes a relatively, in cardiac time, which is very short, it takes a relatively long time for it to get from here to there, okay? Because it slows down, it pauses. Who knows anything about the speed of impulse conduction in the accessory pathway? Does anybody know?
Faster.
Yeah, it's normal. It's just like normal cardiac tissue. So what that means is the impulses probably hit the top of the accessory pathway and the top of the AV node at about the same time. However, they get to the ventricles quicker here than here, because there's no pause, and we're just talking fractions of seconds, right? There's no pause here, okay? So this impulse comes down through the accessory pathway, and it starts depolarizing the ventricles here, but it's off of the conduction system. So it's slow, okay? So even though it's fast to get down to the ventricles, once it gets to the ventricles, it no longer has the conduction system because it's coming down through the back door into the ventricles. And so depolarization through the ventricles starts out very slowly, okay? Now what happens when there is slow depolarization in the ventricles? What happens to the QRS? It widens out. This is the bottom of the QRS. We start having slow depolarization here. And this is it here, this arrow here. It's depolarizing the ventricles through the back door very slowly. The QRS begins as wide. But meanwhile, even though it takes a while for the impulse to get here, once it gets here, it goes very fast because it's got the conduction system. And it comes down and it comes up and it overwhelms, it takes over. It's like two waves, it's exactly like two waves hitting each other. And this wave is going up, is much bigger and much faster than this wave that's coming down, that's slower and smaller. So this overwhelms the other one. So when we look at the delta wave, this is the depolarization that's happening from the accessory pathway, from the back door, the slow, wide. See, it starts off, and if there was no AV node conduction, it would stay wide, okay? But then the AV node takes a while to catch up, but once it catches up, it takes over that impulse that comes down through the AV node. So it's fast and narrow. So that's what causes the delta wave. And if I go back to here, I'm not going to read this because this is just exactly what I said. So it's written down for you, okay? But it's so much easier to explain with a picture, okay? So people sort of got that? Okay. So again, when you're looking, this is the delta wave. The PR interval is shorter because of the delta wave. Okay, here's another example. This is a good one. Can you see how the delta wave, can you see it? Now, if you don't know, remember you're about to go into the final exam and you're going to be expected to pick out WPW from a 12 lead. If you're not looking for it, you're going to miss it. But if you're looking for it, you'll see it. You can see how the delta wave is here. That's what you're doing. And if you're careful to measure the PR intervals, you'll always pick it up because the PR intervals are short or shorter. Okay? You see it there? The delta wave? All of these are WPW. See how fat it is at the bottom? Here, look at here, the flipped over one, the AVR. You can see it. Okay. Note, important note. You cannot, WPW, you should consider, the importance of this is you should always consider WPW a difficult 12 lead because it just screws things up, okay? We're not going to go into too much detail because it just varies so much. WPW can mimic LVH. So if you're looking at a 12 lead on the final, for example, and you see WPW, don't also write down LVH, okay? Because you can't tell it. Okay, so for example, this one, I believe, fits the criteria of LVH, but it's also clearly WPW, so you can't say LVH. Here's another one. AVL is bigger than 15, maybe it's LVH. Nope, it's WPW. WPW should be considered difficult 12 lead. It may mimic LVH. Occasionally it mimics a STEMI, okay? So that doesn't mean you shouldn't take note of a STEMI, especially if the signs and symptoms are consistent with ACS. But consider it a difficult 12 lead. However however your service wants you to, does that mean you transmit it? Yes. Does that mean when you're doing your STEMI activation, you should always say, and this person has WPW, because they might want to wait and see the 12 lead themselves. Okay. The only thing left of the class, we are going to get out early. Sorry, I dragged you in 15 minutes early. The only thing that is left, everybody's looking very understandably sleepy. We can either, this will probably take about 10 or 15 minutes. We can either just do it, or if you just want to stand up for 5 minutes to wake up, okay, everybody wake up, whatever it takes. If you look at the back of the LVH handout, you will see suggested 12 lead analysis, how I think it makes sense to go through a 12 lead. Every book there is, every textbook there is on 12 leads has an analysis, and I don't think it works for paramedics, okay? I mean, by all means, go out and look for it, but I will, as I go through, I will tell you why I don't think the standard one works very well, okay? Now, first of all, remember what we said about rate. Always pay attention to the rate. And one of the problems with the typical 12 lead textbook analysis is they always put rate at the top, and that makes sense. It's in some ways the most important thing you're going to get. But by the time we see a 12 lead, we've already know the rate. So that's one of the things, I mean, it's, as a paramedic, unless some doctor hands you a 12 lead and says, tell me about it, typically when you're working, by the time you've got the 12 lead, you should have considered the rate and what it means long before that, okay? But rate should always be the first thing, much more important than, really much more important than anything, even a STEMI. You should make sure that it's not too fast, not too slow, regardless of what the rhythm is. And that's easy. I mean, you just look and say, not too fast, not too slow. Okay? The other thing that I don't like about the standard analysis of a 12 lead is then the second thing they usually have is, figure out, do the intervals and figure out what the rhythm is. Well, again, for paramedics, even though I think it's a handy skill to be able to do it from the 12 lead, by the time we do a 12 lead, you should, for the most part, always know, is it AFib, is it VTAC? You should know that before you do the 12 lead. So that's another thing that I don't think works. Now, I think, and I've said this before, but I think it will really help you a lot. And this is, I've never seen this in any other 12 lead analysis, but I'm also convinced that they do it. They just don't write, they just don't tell you to do it. That somebody who's good at 12 leads looks for a left bundle branch block and looks for LVH before they go any further, okay? They don't tell you to do it, but I'm certain they do. And the reason is, if you see a left bundle branch block pattern and you confirm it, you look and say, oh, I think that's a left bundle branch block. Let me look at V1, let me look at V6, lead 1, does it look like, then you don't have to worry about the ST elevation, right? Except for scarbosa. And so I've seen students do this over and over before they've really learned what a left bundle branch block looks like. They get to that point and they're looking at a left bundle branch block, and I teach you should systematically go through all the leads, right? And they're carefully saying, okay, no ST elevation, oh, a little bit ST depression in V1 and V2. There's elevation in V1, V2, and so forth. You don't have to do that if it's left bundle branch block. So it's a time saver if you can get that out of the way, okay? The same thing with LVH. Once you know it's LVH, it's not that you should ignore the other things, but you already know you've got something which is a notorious septal anterior STEMI mimic. So it makes a difference right from the start. Okay, and then I say what to do. If you find left bundle branch block, check for scarbosa. If you find LVH, look for strain pattern and understand what it means, okay? Then what you should, and that should take like seconds, right? If you're on top of left bundle branch block, you should get it out of the way really quick. That shouldn't take any time at all in LVH, a minute or something. And then you collect additional evidence. And at this point, I think you need to be very systematic, not just zero in on, oh, septal, this is an inferior STEMI. Go through, and again, only takes seconds, just go through, say, elevation, depression, 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 elevation, elevation. If you have a written 12 lead, which you always should have, you should always have it printed out and look at it, and most monitors, that's how you get them anyway, is I would just take your pen and circle elevation, 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 and depression, so then you can look at it and make some sense out of it. And then add in. Remember, we've looked at this one and said, oh yeah, these hyperacute T's really make a difference. So look for T wave changes, I think are important. And if you don't have an obvious lot of elevation, then start looking for the more subtle things, the straightened out T's, the hyperacute T's that are larger than the QRSs. And identify pathological cues. Sure, you might as well. I don't think they're terribly useful. Do the axis if you want. Again, I don't think it's terribly useful myself, but I just stuck it in. And then, of course, inferior STEMI, we all know that's a special case. Depending on what your protocol is, do you just withhold nitro at this point, or do you move V4 over to the right side? If it's a possible posterior, do you want to do anything about it, or because you already have STEMI criteria, you're fine just saying possible posterior, okay? And then if you don't have STEMI criteria lacking, but there's subtle signs of active ACS symptoms, then what do you do if you have this as your 12th lead? What are you going to do? Yeah, absolutely, because I'm using this as subtle signs of you have active ACS symptoms, and I'm saying there's signs of problems here, even if it's not a STEMI activation. What do you see that's problematic then? Which area?
Depression. inferior.
Depression in inferior, and yeah, straightened out, yeah. So based on what I'm seeing here, there's also a little bit of stuff here. This is the area I would do, and I would definitely do serial 12 leads. Okay, widespread ST depression without ST elevation except AVR. Consider non-ST elevation ACS. How many leads? 6, at least 6. And what does bizarre mean in emergency medicine? Hyperkalemia or TCA overdose. This is hyperkalemia though. Okay. And then when in doubt, do serial. And just do it. I mean, for us, it's for us, it's so easy. It doesn't cost anything more other than the paper. Who cares? It's so easy for us. It makes it interesting anyway. Okay. Truly the final words. I keep saying this is the last, but this really is the last. If you want to stay good at 12 leads, and I would say at this stage, everybody in this room is pretty good, probably better than most 12 paramedics out there with 12 leads, okay? If you want to stay that way, you have to practice. There's just no other alternative. And, once every few weeks, just start, dig out some of your resources and practice. And I'll give you a list of resources in a minute. That being said, I think there's like a true bare minimum. If, again, I keep saying, well, this is easy, you just have to remember it. Well, that's the hard part. The only way you're going to remember it, it's not like every day you're going to have 6 patients with STEMIs. So you really are going to have, discipline and motivation in order to keep it going. I think that the bare minimum that a working paramedic should have, if you start losing some of this stuff, is ECG arrhythmia recognition, okay? If you don't quite remember, second degree AV block 2-to-1 conduction, you'll probably be fine, although it's easy to practice. Just pull your Huff book out and work on it for a while. I think you obviously, I hope to everybody, you absolutely have to be able to identify a STEMI. That's the whole point of everything, really, okay? In order to do a good job with the STEMI, I think you absolutely have to be able to recognize the left bundle branch block. And again, if you haven't opened up that file I have where I just have, go ahead and download that. That's like where I've just given you like left bundle branch block after left bundle branch block after left, and the same thing with right bundle. So you can look at the variation. Identify LVH, again, easy, but I identify it and know the significance. And I think to really be able to do a good job, you have to be able to identify hyperkalemia. Because again, if your patient, or at least, and also understand like what happens if you give sucks to a patient and the rhythm changes, what does that mean? I think that you really need that. So I know that unless you really work at it, a lot of the stuff that you've worked very hard in the last 2 terms to learn is, it's true with everything we learned during this year. But if nothing else, keep this live. So I've gone through this before, but I'm going to repeat it. I think it's still $26 a year. They have different levels of membership. Just go for the lowest one. And it's only $26 a year. It's cheap, and you get like once a week you get an ECG case in your email, and you go from there. And if you just did that, like once a week, looked at Amo Matuz, that would keep everything fresh. It really would. Again, for a quick, really concise, useful summary of all this stuff, life in the fast lane cannot be beat. If you want to say, what was it about LVH? Just look it up there. It's easy peasy, okay? And then if you like books, the only one that I can really highly recommend is one that came out about 4 or 5 years ago. called Critical Cases in Electrocardiography. It's terrific, it's great, and it's easy to read. It's not a beginning textbook, but you guys would all be great with it. Gives you lots of examples. Almost all of the repeat ECGs I have came from there. They're all real cases. He's a good writer. Last I checked, it was 76 new, but it's been out for enough years that there's probably some good deals on used stuff. So, okay. And then if you just a quick note is the videos that I have up on YouTube will be there. Usually what I do is I just delete them at the end of the summer. So if you want to look at them, download them, whatever, that's the deadline, end of the summer. So end of August, if you're interested. Okay. That's the end.
No.
I don't wanna go to the real world.
Never licensed now.
Yeah.